Hi everyone, my name is Hadi Zafar, and welcome to First Aid Explained, where I, as a medical student, try my very best to explain in depth every page of the First Aid USMLE Step 1 2021 textbook. In this video, I'll be covering the biochemistry portion, pages 79 to 85. So let's begin. So here on the first page, we have pentose phosphate pathway, also called as the HMP shunt. And this provides a source of NADPH from abundantly available glucose 6P, or glucose 6-phosphate. Now, keep in mind that NADPH is required for reductive reactions, for example, glutathione reduction inside RBCs, fatty acids, and cholesterol biosynthesis. Additionally, this pathway yields ribose for nucleotide synthesis. Two distinct phases of the HMP shunt is oxidative and non-oxidative, both of which occur in the cytoplasm, and no ATP is used or produced in this pathway. Now, the sites of HMP shunt are in lactating mammary glands, liver, adrenal cortex, the sites of fatty acid or steroid synthesis, and RBCs. Now here we have the reactions. So the oxidative and non-oxidative, whereas oxidative is irreversible and non-oxidative is reversible. So you can see here in the oxidative reaction, glucose 6P gets converted with the help of glucose 6P dehydrogenase to 6-phosphogluconate. And this is where one NADP plus gets its H, as a hydrogen molecule. From there, 6-phosphogluconate gets converted into ribulose 5P1. Ribulose 5P gets converted to ribose 5P with the help of phosphopentose isomerase. And this ribose gets later used in nucleotide synthesis. However, some of that ribose, with the help of trans-ketolase B1, or vitamin B1, gets converted to fructose 6P, or glyceraldehyde 3P, which can be converted back to fructose 1,6-biphosphate, or DHAP. Okay, now let's talk about G6pd deficiency, or glucose 6-phosphate dehydrogenase deficiency. Now, NADPH is necessary to keep glutathione reduced, which is in turn detoxifies free radicals and peroxides. Now, decreased NADPH in RBCs leads to hemolytic anemia due to poor RBC defense against oxidizing agents. These oxidizing agents can include flavamines, sulfonamides, nucleophyletones, primaquine, chloroquine, anti-tuberculosis drugs. Now, infection is the most common cause and can also precipitate hemolysis, which is inflammatory response produces free radicals that diffuse into RBCs, causing oxidative damage. So that's why we always need high levels of NADPH to defend the RBCs against oxidizing agents. Now, G6PD is an X-linked recessive disorder and is the most common human enzyme deficiency and is more prevalent among descendants of populations in malaria endemic regions, so sub-Saharan Africa and Southeast Asia. Now, we see something called hen's bodies in patients of G6PD. And these are denatured globin chains precipitate within RBCs due to oxidative stress. And they're also called as bite cells. And this is a result from the phagocytic removal of hen's bodies by splenic macrophages. Think of bite into some hen's ketchup. All right, moving on. Here we have the disorders of fructose metabolism. And we have two main categories, essential fructosuria and hereditary fructose intolerance. Now, essential fructosuria involves a defect in fructokinase, and this disease is autosomal recessive, a benign asymptomatic condition, which is fructokinase deficiency, since fructose is not trapped in the cells. So hexokinase becomes the primary pathway for converting fructose to fructose 6-phosphate. And the symptoms are that fructose appears in the blood and urine. So the disorders of fructose metabolism can cause milder symptoms than analogous disorders of galactose metabolism. So the symptoms are quite mild. just get mostly fructose appearing in the blood and urine. Now, hereditary fructose intolerance, however, is a hereditary deficiency of aldolase B, and this is autosomal recessive. And this is where fructose 1-phosphate accumulates, causing a decrease in available phosphate, which results in inhibition of glycogenolysis and gluconeogenesis. And the symptoms present following consumption of fruit, juice, or honey. Now, a urine dipstick test will be always negative, as this tests for glucose only and not for fructose. Now, reducing sugar can be detected in urine, which is not a specific test for inborn errors of carbohydrate metabolism. And the symptoms for hereditary fructose intolerance are hypoglycemia, jaundice, cirrhosis, and vomiting. And the treatment is the decreased intake of fructose and sucrose, because sucrose is glucose plus fructose, and sorbitol, which is metabolized to fructose. So again, essential fructoseria is a defect in fructokinase, and hereditary fructose intolerance is the hereditary deficiency of aldolase B. Okay, now let's talk about the disorders of galactose metabolism. Now, a galactokinase deficiency is a hereditary deficiency of galactokinase. Galactitol accumulates if galactose is present in diet. Relatively mild condition, and the symptoms are quite vague. And this is autosomal recessive. Now, the symptoms include galactose appearing in the blood, galactosemia, and urine, galactosuria, and infantile cataracts, and may present as failure to track objects or to develop a social smile. Now, galactokinase deficiency is kinder. It's a benign condition. Now, let's talk about classic galactosemia. Well, this is the absence of galactose 1-phosphate uridyltransferase, and this is, again, autosomal recessive. Now, the damage is caused by accumulation of toxic substances, including galactitol, which accumulates in the lens of the eye. Now, symptoms develop when infant begins feeding, as lactose present in the breast milk and routine formula, and include failure to thrive, jaundice, hepatomegaly, infantile cataracts, intellectual disability, and can predispose to E. coli sepsis in neonates. And the treatment involves excluding galactose and lactose from the diet. A really nice mnemonic to remember both disorders of galactose and fructose metabolism is that fructose is aldolase B, as galactose is uridyltransferase. So FAB-GUT, fab gut. All right. Now, next we have sorbitol. And this is an alternative method of trapping glucose in the cell, as it can be converted to alcohol and alcohol's counterpart, which is sorbitol, via aldolase reductase. Now, some tissues then convert sorbitol to fructose using sorbitol dehydrogenase. Tissues with an insufficient amount or activity of this enzyme are at risk of intracellular sorbitol accumulation, causing osmotic damage, with cataracts, retinopathy, and peripheral neuropathy, seen with chronic hyperglycemia and diabetes. High blood levels of galactose also result in conversion to the osmotically active galactitol via aldolase reductase. So liver, ovaries, seminal vesicles have both enzymes. They lose sorbitol. Whereas lens has primary aldolase reductase. The retina, kidneys, and Schwann cells have only one aldose reductase. Next, we have lactase deficiency. And this is insufficient lactase enzyme, which is dietary lactose intolerance. Now, lactase functions as an intestinal brush border to digest lactose. This is found in milk and milk products, into glucose and galactose. Now, primary lactase deficiency is age-dependent decline after childhood. And this is the absence of lactase-persistent allele, common in people of Asian, African, or Native American descent. Now, secondary lactase deficiency is a loss of intestinal brush border due to gastroenteritis, or rotavirus, for example, can cause this, autoimmune disease, or congenital lactase deficiency. And this is rare, as is due to a defective gene. Now, stool demonstrates decreased in pH, and breath shows increased hydrogen content with lactose hydrogen breath test. whereas the H plus is produced when colonic bacteria ferment undigested lactose. Now, intestinal biopsy reveals in lactase deficient patients that normal mucosa with hereditary lactose intolerance. Now, the findings of lactase deficiency patients is bloating, cramps, flatulence, and osmotic diarrhea. And the treatment is to avoid dairy products or add lactase pills to diet or lactose-free milk. Okay, next we're going to talk about the amino acids, the essential, the acidic, and the basic. Now, keep in mind that only L amino acids are found in proteins. To remember all the essential amino acids, keep in mind of the mnemonic PVT Tim Hall. So PVT, Private Tim Hall. Next, we have the acidic amino acids, and this is aspartic acid and glutamic acid. And they're negatively charged at the body pH. Now, to remember the basic amino acids, remember his Lys or his LYS are basic. And arginine is the most basic amino acid. All right. Next, we have the urea cycle. And this is where amino acid catabolism generates common metabolites. For example, pyruvate or acetyl-CoA, which serves as metabolic fuels. Excess nitrogen is converted to urea and excreted by the kidneys. And here we have a diagram showing or depicting the urea cycle. Next diagram, we have the transport of ammonia by alanine. And this transport uses both the Cahill cycle and the Cori cycle. And is between the muscle and the liver, muscle being the start of the process and liver being at the end. All right, next we have hyperammonemia, which is acquired, for example, liver disease, or hereditary, for example, urea cycle enzyme deficiencies, and presents with flapping tremor or asterisks, slurring of speech, somnolence, vomiting, cerebral edema, and blurring of vision. There's an increase of NH3, and this changes relative amounts of alpha-ketoglutarate, glutamate, GABA, and glutamine to favor increased glutamine. Now, Cns toxicity may involve in decreased GABA or decreased alpha-ketoglutarate, T cycle inhibition, and cerebral edema due to glutamate-induced osmotic shifts. Now, the treatment for hyperammonemia is limit protein in diet and may be given to decreased ammonia levels. So we can give lactulose to acidify GI tract and trap NH4+ for excretion, antibiotics such as rifaximin and neomycin to decrease aminogenic bacteria, benzoate, phenylacetoate, or phenylbutyrate react with glycine and glutamine, forming products that are excreted renally. All right. Next, we have the Orentine Carbomylase Deficiency, and this is the most common urea cycle disorder, and this is X-linked recessive. And compared to other urea cycle enzyme deficiencies, which are mostly autosomal recessive. Now, Orentine Carbomylase Deficiency interferes with the body's ability to eliminate ammonia, and often is evident in the first few days of life, but may present later. Now, excess carbamyl phosphate is converted to uric acid, part of the pyrimidine synthesis pathway. And the findings of these patients are there's increased uric acid in the blood and urine, decreased BUN, symptoms of hyperammonemia, and no megoblastic anemia versus uric aciduria. Next, we have a diagram depicting the amino acid derivatives, showing us histidine to histamine, glycine to porphyrin and heme, glutamate to GABA and glutathione, arginine to carotene, urea, and nitric oxide, and the most importantly, phenylene, which converts into tyrosine, or to thyroxine, dopa to melanin, and dopamine to vitamin C, and SAM to epi. Next, we have a diagram depicting the catecholamine synthesis, or tyrosine catabolism. Now, during this cycle, if there's a defective homogeneous oxidase enzyme, the patient have Alkaptonuria. If there's a defective phenylalanine hydroxylase, PKU could be the possible cause, as well as tyrosine leading to albinism. Okay. Next we have Phenoketonuria. And this is caused by the decreased phenylalanine hydroxylase or decrease in tetrahydrobiopyridine, BH4 cofactor, which is called as malignant PKU. Now, tyrosine becomes essential, increasing the phenylalanine and increasing phenol ketones in urine. And the findings of this disease or disorder is intellectual disability, microcephaly, seizures, hypopigmented skin, eczema, and musty body odor. And the treatment is to decrease phenylalanine and increase tyrosine in the diet. So tetrahydrobiopyridine supplementation. Next is maternal PKU, which is due to elevated maternal phenylalanine levels and can be prevented by dietary intake. Findings in infant are microcephaly, intellectual disability, growth restriction, and congenital heart defects. Now, phenylketonuria is autosomal recessive, and the incidence is 1 out of 10,000. Screening occurs between 2 to 3 days after birth, normal at birth because of maternal enzyme during fetal life. Now, phenylketones, phenylacetate, phenylactate, and phenylpyruvate leads to disorder of aromatic amino acid metabolism, which gives that musty body odor. PKU patients must avoid the artificial sweetener aspartame, which contains phenylalanine. Next we have maple syrup urine disease, and this is blocked degeneration of branched amino acids, so isoleucine, leucine, and valine, and due to a decreased branched chain alpha keto acid dehydrogenase, or vitamin B1, and this causes increased alpha keto acids in the blood, especially those of leucine. And the treatment is restriction of isoleucine, leucine, and valine in the diet, and thiamine supplementation. Now, maple syrup urine disease is autosomal recessive, and the presentation is vomiting, poor feeding, urine smells like maple syrup or burnt sugar. This is the most important part. And this causes progressive neurological decline. Next, we have Alkaptonuria, which is congenital deficiency of homogenase oxidase in the degradative pathway of tyrosine to fumarate, leading to pigment-forming homogenesic acid buildups in tissue, which you can see here in picture A. And this is autosomal recessive and usually benign. The findings are bluish-black connective tissue, ear cartilage, and sclera. Urine turns black on prolonged exposure to air. May have debilitating arthralgias due to homogeneic acid toxic to cartilage. Alright, finally we have homocystinuria, and the causes of which are all autosomal recessive, which are cysteine synthase deficiency, and the treatment for this is in decreased methanoidin and increased cysteine and vitamin B6 and 12 folate in diet. Decreased affinity for cysteine synthase for peroxyl phosphate, and the treatment is increased vitamin B6 and cysteine in the diet. Methanoidin synthase deficiency or defect or homocysteine methyltransferase and the deficiency, and the treatment of increased methanoidin in the diet. Methylentetrahydrofolate reductase, MTHFR deficiency, could also be a cause of homocystinuria, and the treatment is increased folate in diet. Now, all forms result in excessive homocysteine. Now, homocystinuria leading to increased homocysteine in urine, osteoporosis, marfanoid habitus, ocular changes, so downward and inward lens subluxation, cardiovascular effects, thrombosis and atherosclerosis, so they can lead to stroke and MI, kyphosis, intellectual disability, hypopigmented skin. In homocystinuria, lens sublux down and in versus marfan's up and fans out. Next, we have Cysteine Urea, and this is a hereditary defect of renal PCT and intestinal amino acid transporter that prevents reabsorption of cysteine ornithine, lysine, and arginine, COLA, COLA. Now, cysteine is made up of two cysteines connected by a disulfide bond. Now, excess cysteine in the urine can lead to recurrent precipitation of hexagonal cysteine stones, as you can see in picture A. And the treatment is urinal alkalization, for example, potassium citrate and acetozolamide, and chelating agents, for example, penicillamine, and increased solubility of cysteine stones, due to good hydration and diet and lowered methionine. Now, Cysteine is autosomal recessive and is quite common, 1 out of 7,000. Now, cysteine detected with urea sodium cyanide nitropyrroside test and proton nuclear magnetic resonance spectroscopy of urine. Now let's talk about organic acidemias, and this most commonly presents in infancy with poor feeding, vomiting, hypotonia, and high anion gap. Metabolic acidosis, hepatomegaly, seizures are also found. Now, organic acid accumulation inhibits gluconeogenesis, decreasing fasting blood glucose levels, and increasing ketoacidosis, or a high anion gap, and metabolic acidosis occurs. Also, organic acid accumulation leads to inhibition of the urea cycle. Hyperammonia occurs. Next, we have propionic acidemia, and this is a deficiency of propionyl CoA carboxylase, leads to increased propionyl CoA and decreased methylmalonic acid. And the treatment for this is a low-protein diet limited in substances that metabolize into propionyl 1 CoA, so valine, odd, chain fatty acids, methionine, isoleucine, and threonine. Now, methylmalonic acidemia is a deficiency of methylmalonyl CoA mutase or vitamin B12, and the treatment is the same. All right, that's it for today. Thank you so much for listening, and have a great day.